Good morning, everybody. We're going to call the meeting to order. Welcome. All those of you online, be sure and do the QR code or the link at the end of the presentation. So I'll know that you were online, please, so you can get credit for there. Want to start off with Will Losey from UHC and UHTH doing multiple things today. All right. We have a new clicker.
New clicker. All right.
And it actually works.
It works.
Now click it.
All right, guys. So I've got a stroke and then a pair of different cases to talk to you about. You're welcome. So our first one was 82-year-old female. She had a history of CVA, TIA, coronary artery disease. Call for 911 for a possible stroke.
It works.
So right to the highlights we go. All right. Well, if you just want to use the arrows again, you can, but it actually was working for me.
So EMS was called at 3:34, arrived on scene at 38 after, departed the scene at 4:01, so 23 minutes on scene. Stroke alert was called at 4:10, and they arrived in Clinton at 4:16. The run report on this one, upon arrival, found an 82-year-old female sitting on the edge of her bed, leaning to the left side against her daughter. Daughter states that the patient fell from bed, which woke her up. When she came to help her, she noticed that the patient had a facial droop. Daughter states that she couldn't help herself up, completely left side, flaccid, unable to use her limbs. EMS notes the facial droop as well as the loss of the left side. Daughter reports that her mother has a history of mini strokes. The last one 3 to 4 months ago was in April. And it notes that she's also slow to speak and has slurred speech. She's alert to her normal. However, the speech was abnormal for her. Daughter reports that the patient had no deficits from the previous stroke. At this time, due to the size of the house and the inability for the patient to ambulate, they did call for lift assist and a driver, which extended that 23-minute on scene time. Daughter reports the last known normal was 2200 last night before she went to bed. Patient is unsure as far as the onset of her symptoms. Does say that she may have struck her head when she fell, and there was some bruising noted underneath the right eye. Denies any loss of consciousness. Patient has loss of function to her entire left side of the body, only able to raise her right arm. When spoken to, she has an abandoned gaze to the right, but is still responsive. Put her on some O's for comfort. Monitor her on the way in. Hiring called upon arrival, and then once they got to the ER, proceeded directly to CT with the patient. So the 2200 is when they came in the door. Stroke alert called at 19 to alert CT prior to arriving. Tell the neuro page at 4:32, the consult at 39. At 5:14, the patient was taken back to CT for CTA head and neck to rule out LVO. And 6:07, rad partners called with a critical finding, thrombus in the proximal into segment right middle cerebral artery. This patient was not eligible for T&K due to the onset. She was outside of the treatment window. The CTA showed her thrombus. We ended up setting up for her to go to St. Vincent's. Unfortunately, due to the weather, air transport was not an option. And ground transport was pretty tied up that particular day. So it ended up being in St. Vincent's critical care ground, coming from Indianapolis to pick them up. So it was out of the ER at 8:40. 4 hours, 18 minutes in the ED. For critical access, we participate in the American Heart Association rural data set. We have a 90-minute goal to get those patients out. So fortunately, we'll be on that. On this one, fantastic documentation. Had both the stroke scale bands charted. Pre-notification was done, clear documentation as the last known well. Again, with the house and call for listing assist, that did prolong the time. And then also got delayed in our ED to get around to Indianapolis. So this was her actual imaging. Got a nice full-on line there. I scrolled up on this side, so that's the continuation that we should be seeing here. That was her clot. Our first STEMI is a 42-year-old male, history of hypertension, anxiety, depression. One called out for mental chest pain. UMS notified 11:22, arrived on scene 11:27, departed at 46, STEMI alert at 11:50. They have the arrival time charted at 12:30. I think that's actually the departure time, because you're gonna see when we get into the ER time, stuff was happening before 12:30. So they arrived to find a male sitting, talking with first responders, pink, warm, dry, speaking full sentences, no obvious distress. Reports that he woke up that morning with chest pain, thought it was his anxiety, took his medications, and the pain went away, but returned later that morning. Once they got into the ambulance for their assessment, vitals obtained, noted that his blood pressure was high, but the patient felt that was due to his anxiety. Well, 12D initially had a lot of artifacts, but repeated it, and the repeat showed inferior STEMI with reciprocal interior changes. Transport initiated emergent, 324 aspirin was given, nitro was held due to the inferior involvement. Lead tech requested the dispatch call ahead early due to how far they were out. Fantastic. Multiple 12 leads were obtained with transport. Didn't have any further elevation in the EKG. Verbal report, Nyhern called approximately 6 minutes out. 12:17 arrived in the ED. 12:19 EKG was done, again showing inferior STEMI. 20:48, patient arrived in cath lab. 21:10 was the first ballooning. So first medical contact was 154 on this one, door to balloon 105. This gentleman had,
Those times
Will,
weren't right.
is that right?
Those
In
times.
the 8-hour ER stay?
I'm sorry,
It says 12:19 EKG obtained showing STEMI, but 20:48 was cath lab arrival.
yeah.
Yeah, 8
That's
hours.
8 hours.
8 hours.
12:48.
Oh, I see what you're, I'm sorry. No, that is
12:48 is
12, yeah, 12:48. Thank you.
13:10.
Catch that. The times on this one, were lengthy. We had a really long, arrival time for the cardiologist on this one, which is one of the things, that we spoke about at our last chest pain team meeting, as far as trying to tighten those things up. Good catch. Yeah, this one was activated pre-arrival, yeah. We still, unfortunately, got killed one of those times. This one had a pair of blockages. So that is first is a complete loss of that branch. And then there's also a branch off of the RCA. They were able to get back opened up. This one, I loved all the efforts they went to give us that pre-arrival. This is one that, in a perfect world, they should have crushed on time. But fortunately, we had a long cardiology. So you get the cap up there. And then we got a 62-year-old male. Only history was that of smoking. Called 911 at chest pain radiating into both of his arms. EMS notified at 12, arrived 12:18, departed 12:37. STEMI alert 13:07. I put that asterisk on there. That is the actual Ihern time, but due to the notations in the chart, it sounded like there was a phone call prior, but I don't have a way to track that. And then arrived in Hospital Terre Haute at 13:09. So dispatch for a 62-year-old male complaining of chest pain, radiating down both upper arms. On arrival, ANO ×4, lying in bed. Pale, cool, clammy, diaphoretic. States that him and his wife are having extracurricular activities. And sudden onset of sharp stabbing chest pain in the middle of his chest, radiating down both arms. I didn't leave it in here, but they did note that there was assessment for ED medication, so good job on them for that. Vital signs were assessed. The finger stick was 86. Hooked up to cardiac monitor, 12 lead. EKG almost immediately shows elevations in 2, 3, AVF, E3, 4, and 5. With reciprocal changes in 1 AVF. Noted inferior anterior STEMI. Oxygen was applied. Will be established. They continued to monitor his 12 lead. 324 of aspirin was given. Rating pain out of 4 to 10. Continued to radiate down both of his arms. Stimulator was called in prior to arrival. 13:16 rolled into the ED. 13:18 EKG again confirmed STEMI. 13:38 arrived in cath lab. 14:4 open. First medical contact 125 door to balloon of 68. It's always satisfying to see those RCAs get opened up. So the proximal RCA restored all fluid. So they did note, right-sided EKG to look for right-sided involvement with the inferior STEMI. Kudos to them. This one came from Casey, Illinois, so has a lot to do with that first medical contact reperfusion time being extended. It was a 36-minute drive to the work. And cath lab and cardio were activated prior to arrival of the patient on this one as well. Questions, thoughts? Other than I need to get my times right.
Thanks, Will, appreciate that. Next up's gonna be Beth Harrison. She's gonna have a stroke case for us from here at Union Hospital Terre Haute.
Good morning, everyone.
If not
I'm a least techie person, you know, so
there.
We'll see how much I
Do the arrows.
I'm gonna do the air. I'll be honest.
That's fine.
This history of this case, he's a 60-year-old male, lived at home independent with his wife. Prior medical history includes hypertension and diabetes. His only home medication was Genumet and no blood thinners. His last done well was 0325. EMS was notified at 0412. Dispatch was 0412. En route at 0414. On scene of 0419. And there was no data when they were at the patient. It was kind of an outlying area, so it was kind of unclear to me. Present history, EMS was dispatched to a private residence. Upon arrival, they found the patient sitting on the floor in the living room. Family reports that the patient crawled into the room. His last known well was at 3:25 that morning. He was getting ready for bed, and he denies going to sleep after not going. I'm sorry, he denies having any sleeping after his symptom onset, so we do believe his last known time was correct. The patient presented with loss of grip in his right hand and no movement in the right leg. His finger stick blood sugar was 430. 12 lead EKG shows sinus rhythm. He was diaphoretic and a 20 gauge IV was started. You notice he was not on any antihypertensives, but his pressures were okay. Good, his blood sugar was way out of control. Union ER was notified via iHearn of the stroke alert. There was no stroke scale documented, but there was a very good narrative report by EMS in the chart. Upon arrival, EMS departed the scene at 0438. Stroke alert was called at 0452, and they arrived at Union at 0458. In the emergency room, patient called, went directly from CT for the EMS cart. They actually arrived at our ER by our documentation at 0500. So that's where our times are based on. And the ER, his NIH was 11. At 0502, teleneuro was paged. 0504, the ER doctor put in stroke CT orders. 0509, the teleneuro video start. 0511, CT was completed. 0517, the CT was negative for bleed. TNK was given at order 0518, and the mix was started at that time. In 0521, TNK was given. So this patient actually had a 21-minute door to needle time, which is phenomenal. 0631, he did go back to CTA for a CTA of the head and neck with perfusion, and they utilized our rapid software with that, and no LVO was identified. At 1300, the neurohospitalist did evaluate the patient. And at that time, he had severe expressive aphasia, right facial droop, a plegic right upper extremity, and 2-5 strength lower extremity with numbness. If you remember with his presenting symptoms, his leg was plegic, but he did have some in the hand. At 0546, MRI resulted and did show a left pontine infarct. Disposition on 10/1 of this year, the patient was discharged to acute inpatient rehab. And at that time, he had 2-5 strength in his upper extremity and his lower extremity. So he's gone from being plegic to having 2-5 strength. But he did still have expressive aphasia. And on the 9th, he was discharged home with improving deficits and was able to transfer without assistance. So I honestly think if he had not gotten here, gotten that TNK, we would have had a very different outcome for this patient. So that time was phenomenal. Because data does show, even if we don't see, sometimes you can push TNK and you have a miraculous turnaround. But data shows that even those patients who don't have that miraculous turnaround in the ER, at 3, 6, and 9 months, they have much better outcomes than those patients who were never treated with TNK. And I think this patient showed it. And I did look in there. He had a recent physician visit. He has continued to improve. His speech is better. And I do believe that his lower extremity was documented at 4 or 5 strength. So he is going to have a miraculous recovery. It was some excellent work. Highlights, great narrative condition by the EMS. They had a great picture. You could just see it through the narration of what was going on there. The stroke alert was called, and even in their charting was directed where they were going, heart to CT1. But there's just no pre-hospital stroke scale completed, no van completed. Excellent work by EMS and Union ER staff, so thank you.
Thanks, Beth, appreciate that. Next up is gonna be Tina. She's gonna have her trauma report. I think, they had to look down and see what. Oh, you're. Yeah, right in front of everybody. Yeah.
Good morning. I just have one case today, so Merry Christmas. This was a 95-year-old female. She had a fall. 911 call came in at 15:33. They were dispatched 15:33 en route 15:38, on the scene at 15:40, and departed the scene at 15:50, and was at Union ER 16:30. It was in Outline County. Call dispatch is a minute, dispatch en route was 0 minutes, en route to arrival was 2 minutes, on the scene to departure 10 minutes, departure to arrival in the ER was 40 minutes, total time 43 minutes. So this was a 95-year-old woman who was dispatched for a fall. Her ankle with an ankle injury that was bleeding. On arrival, there was a lot of people in the residence. She was sitting on the floor, resting against a recliner. So a neighbor had come to check on her, so when she got up out of the recliner, she fell. There was no loss of consciousness. She was literally times 4. She does take Plavix. She was the cutest little 95-year-old woman. You would never guess she was 95. She had an obvious enormity to her right ankle. She was complaining of numbness in her right foot, 2 to 10 of pain. When it was just testing 10 of 10 movement. She was able to refill was 4 seconds. Plus radial pulse in the right foot, 1 plus pedal pulse. Right foot was literally just attached by skin. It was just kind of hanging. And it was rotated outward. Vitals, blood pressure was 200/96. Pulse was 84. Rest 17. Stat was 98 on room air. ECS was 15. And CO2 entitled was 38. They supported her leg, moved her to a cot, secured her, put her on the monitor, started an IV, gave her fentanyl ×2, Zofran, the O2 on her because of the narcotics. She was oozing some blood from the open fracture, but it was just intermittent. It wasn't uncontrolled. I heard with trauma alert due to weak pulse in the right foot. They were really having trouble finding the pulse. So she was transported to the ER and went to trauma 3. Pre-arrival note said she fell getting out of her recliner. She had an open right tib fib with a weak pulse. Trauma alert level 1 was called at 16:20. So she met criteria of under like the megal pulseless crushed extremity injury because the pulse was so weak. So they did call the level 1. She arrived at 16:31. Trauma surgeon was already in the trauma room. Vitals was 96.7. Pulse 59. Rest 12. Blood pressure was 159 or 58 of 59. 100% sat on 2 liters. DCS was 15. She is awake and alert. Ground level fall did not hit her head. She had an open distal tibia ankle fracture with exposed tibia and ankle dislocation. palpable pulses. They were able to get them with the Doppler, and was able to palpate them. Intact sensation, light touch distally. Motor was intact, neuro was intact. She actually was able to wiggle her toes a little bit. Ortho was consulted. They saw her in the ER. They did an ankle reduction and splinted her. Gave her antibiotics at 16:55, so they met the open fracture antibiotic time criteria. Gave her tetanus. Of course, they said she was to be non-weight bearing. They put betadine over the wound, betadine gauze, and planned for OR in the morning. Images, pelvis was negative, chest x-ray was negative, and then the right ankle showed the open fracture, subluxation, and swelling and effusion. She did have a history of kidney injury or kidney disease, chronic kidney disease. BN was 30, creatinine was 1.90. She'd seen nephrologists in the past. So she was admitted to the hospitalist with ortho consult. Diagnosis was a grade 3 of right tibia and fibula fracture. And there's some pictures. You know, I love pictures. But this was a really, but it was very neat fracture. And she was just laying there, just talking to us and smiling. So either fentanyl was really good, or she has a really high pain tolerance. Cause she just would, you know, kind of grimace and moan when we moved her foot, but she was really awesome.
Yeah, safe, not good.
Yeah, she jacked that up.
That's a technical term, right?
Yeah, it's, oh, girl, look at that, but then you're looking at her like, wait, that's okay, we can fix this, you know? And then that was after the alignment. Wow.
Still.
Yeah, they did a good job. So, she of course was admitted, went to surgery the next day. Her pain was controlled. Labs weren't any different. Her vitals were still stable. But because of her age, they had a cardiac consult come in for clearance. And they cleared her, but they low to moderate or intermediate risk just because of her age. She went to OR for an irrigation debridement and took care of the open wound, did internal fixation on that fracture. Non-weight bearing PTOT, ice and elevate, ordered Capsol 24 hours, aspirin post-op day 1 through 6, and then they could resume her Plavix on day 7. And she was followed up with ortho for 2 weeks. Day 3, PTOT recommended medical rehab. Hemoglobin was 10.5, UN and creatinine were coming down. Cardiac signed off. She could flex and extend her right ankle with some pain. Splint and dressings were intact and clean. They did right ankle x-ray and there were no post-op changes. Case management was working on sniff. Let's see, day 4, she could do light touch with the right foot with her splint on. Vitals were stable and pain was controlled. Day 5, vitals were stable, pain was controlled. And she discharged to sniff. So for that bad of a fracture, total 5 days, she did really, really well.
At 95.
So, I mean, I think, you know, they called it in trauma alert. They felt they couldn't feel the pulses well, so they did what they needed to do. They called it in. Our staff called it level 1, which was the right thing to do. Got the antibiotics in time. He went to surgery within a 24-hour window, which is apparently what the ortho trauma says is a acceptable time frame. And he had a really good outcome.
But EMS didn't do antibiotics, right?
No, but it was an outlying agency. I don't know that they could.
It just depends on whether they function on our protocol or not.
Yeah. Yeah. Okay.
All right, thanks, Tina. Appreciate it. Up next is Chris Thomas, who's got a case review for us.
Sure, okay. So, after this case happened back in July, I was actually talking to Barry about it, and he said in what 30 years that he's been doing this, he's never seen anything like this case. It's probably the most bizarre thing I've seen in the 22 years that I've been doing it. And when I spoke to the EMS liaison at St. Vincent about it to get the patient follow-up, they pulled it as a trauma case review up there because it was so abnormal. You know about this one, don't you? So, anyway, so started out as a call for breathing difficulty at about 2:30 in the morning. See, there's a little bit of a delay getting en route there. Initially, I guess there was some confusion on the location of the residence. They started a different truck. When they realized we were closer, they got us started. So we didn't get out the door on it until about 7 minutes after it came out. We arrived on scene about 10 minutes later. Sealyville Fire was already on scene. They already had all the initial treatment started on her. We got led to the back of the house by her husband, who was comparable in age, probably in his 80s. And luckily, it was a big enough house, we could actually get the cot to her. That doesn't happen often enough. Found her laying in bed. She was about 350 pounds, laying left lateral in bed. Little bit of an increased work of breathing, not anything too scary, a little dusky in the lips. Sealyville had her on 6 liters nasal cannula, had her hooked up to their monitor. So all of her vitals were already displayed when I walked in the room. She was at 93% on the 6 liters. They advised that she was 88% on room air, which she's baseline room air at home. She wears CPAP at night. It was sitting there next to her bed on the nightstand. So I noticed, and I think it's on the next slide, I'm getting ahead of myself, I haven't seen this in like 2 months. But as I was sitting there talking to her, the first thing I noticed, she's got this gash above her right eye, it's fresh. And so I asked them about that, and she had fallen about 4 hours prior, while getting ready for bed, kind of just shrugged it off, got into bed, and woke up acutely with this breathing difficulty. She is on Xarelto due to the history of AFib, which she was on. That was the initial 12 lead that Fire obtained for us. And then she had the history of COPD as far as respiratory goes. So had some mild tachypnea. She was able to speak in complete sentences. She denied any chest pain. That she had a little bit of head pain around the location of the laceration to her eye. Had, like I said, a little bit of dustiness around her lips. Listened to her lung sounds. She was diminished but moving air bilaterally. And then, like I already mentioned, she had the laceration above her eye. So when she sat up so we can move her to the cot, she rapidly declined. I've never seen someone decline so quick in my entire career. I mean, it's like someone flipped on the cyanotic switch on her, and she just started turning blue extremely fast. We got her up, got her onto the cot. She was gasping for air, almost as if she was choking. Mouth open, gasping, but not making any sounds. Started to become combative, little hypoxic rage going on, most likely, as far as that goes. Ripping the neb treatment off of her face. Tripoding essentially as much as she could on the cot as we moved her out to the ambulance, which of course the driveway was nothing but big rocks. So obviously, it was obvious she was in need of an immediate airway. I told Leslie before we even walked out of the bedroom that we were gonna have to tube her. I mean, she was just declining way too quick. When we got out to the truck, it became quite the wrestling match. It was me and Les and then 2 guys from Sealyville in the back of the truck, and she wasn't sitting still. She went and laid back. Obviously, I mean, she can't breathe. It's understandable. At one point early on, I told them, I'm like, we're gonna have to bag her. She's not ventilating, she's not moving air. So they're trying to bag her consciously. She reaches up at one point and literally rips the BVM apart, completely rips the reservoir bag off of the BVM. She's diaphoretic as heck. And so I finally get an IV in her hand. One of the Sealyville guys is holding her arm for me while I move over to draw up some sedation. And as I'm pulling up the sedation, I just hear him say, Chris, and I look over and just blood's pouring out because the IV came out and while he was trying to wrestle with her arm. And so now I'm on the opposite side of her, and it was about that time that she went out, right? I just moved her arm over on her right side to look for more access, and she lost consciousness, which in my head, I'm thinking, thank God, you know? Oh, as a side note, while I was still on the other side, her sweet little husband opened up the back door, and this was before the IV came out and everything before, and he's like, how's everything going in here? And it's like WrestleMania 10 in the background. You got Leslie back there, and the guys from Sealyville fighting with her and stuff, and so I try to very quickly explain to him, you know, what we're doing and close the door. So when coming back to, she lost consciousness. Again, good for us, bad for her, obviously showing significant hypoxia at this point. Didn't even have a pulse ox because nothing was staying on during the fight, I guess, if you want to call it that. So at this point, we have replaced the BVM. and we're trying to bag her up. I pop an IO into her humerus. She had had bilateral knee replacements, so I just went with a right humeral head IO. Went ahead and gave her some ketamine. And obviously the goal at this point is bagging her up. Before we go any further to try to paralyze her and intubate her, we have to get her oxygenated. So me and one of the guys from Sea Level are attempting to do basically a two-person technique, get a really good seal, and she will not ventilate. She is not ventilating, she is not oxygenating. In hindsight now, I know why, and we'll get to that. But in the moment, it was extremely infuriating. And we could not get this lady to oxygenate. So at this point, I said, we're just gonna do it. I'm not gonna paralyze her though. What little bit of breathing she's doing, we're going to keep her doing that. So we held off on paralyzing her. And as soon as I opened her jaw to insert the laryngoscope, her tongue pops out and it's massively, well, it's purple for one thing, obviously, and it's just huge. And so we quickly were like, is this some kind of allergic reaction? She doesn't have any other indications of an allergic reaction at this point. So I kind of work around that with the scope the best I can. And she basically had a core macula Hayne view of 4, just could not see anything. Literally, probably the most difficult airway I've ever seen in my career. When I was flying, we were mandated to always use a bougie, so I picked up the habit of always using a bougie when I intubate when I started flying, and so I already had a bougie in hand for this, which was actually the lifesaver in this particular situation. So I was able to just slide it in there. Obviously, anatomically, we know where the boards are, so I aimed interiorly, and I was just telling her, I was like, I can feel the clicks of the trachea, so couldn't see anything. It was all completely blind. Getting the bougie in. So we passed the tube real quick. And of course, we're moving really, really fast at this point, trying to get her oxygenated. We do get the tube in and start bagging her. And all the confirmation things are good. She's got good condensation, good CO2. She's moving air in her lungs. But by this point, she had just been hypoxic for too long and she arrested. So immediately started doing CPR, pushed epi right away. I think CPR lasted for about 3 minutes, maybe 3.5 minutes, not very long at all. Enough that Trevor was getting tired, I know that much. 2 rounds of epi, we had a rapid increase in her CO2, which obviously indicated return of perfusion. She had good pulses. Her heart rate had jumped up to the 210s at that point with the pressure 70s over 50s. I kind of sat there and juggled in my head with whether or not I was going to treat the heart rate. I decided not to and just decided that was probably just due to the epi. I was just gonna leave it alone and let things normalize instead of going off and trying to shock her and all that kind of stuff. Ended up being the right decision. She ended up returning to normal a few minutes later. So anyway, once she was intubated and being oxygenated and ventilated, everything was returning to normal. Skin color, temperature, condition improved drastically. Heart rate came down to the 110s, blood pressure normalized into the 130s over 90s. Got her up to 98% on 60% FiO2 on the vent, PVA5. Once we got her to the ER, I think I gave her, she started kind of moving around a little bit because I remember we put her in soft restraints. Gave her like 2 of Versed. And once we got her to the hospital, there were no other incidents on the way in. Dr. Patel came in, he did a quick neuro exam on her. She was able to follow commands briskly. She squeezed fingers immediately. First time he asks, she was able to lift her legs immediately when he asked. So that was all very positive and reassuring to us. However, they did find a non-displaced C6 fracture, which obviously came from the fall that she had sustained. And the big problem, however, was they found a huge hematoma in her neck that originated at the side of the fracture, and it expanded all the way down to her heart through the mediastinum. And then, of course, she's on Xarelto, so that didn't help anything. So essentially, what was happening was that hematoma was expanding and it was squishing her trachea from the inside, which is why she looked like she was choking. And the working theory is, when she was laying on her left side, it's kind of like when you lay the pregnant lady on her left side. It was moving the hematoma off the trachea, and then when she sat up, it compressed it again. So they transported her to St. Vincent Hospital. There's the CT of the hematoma. If you know what you're looking at, that whole grayed out area there is not supposed to be there. And you can see the fracture a little bit there. It's not circled. They transferred her to St. Vincent. When she arrived there, she was no different than when she left the ER, had GCS of 11, would have been 15 if she wasn't intubated, but still briskly following commands. They moved her up to the ICU, but they were unable to evacuate the hematoma, and it actually continued to expand over the next week to the point it actually compressed her carotid arteries and cut off blood flow to her brain. And so then exactly 1 week later, they terminally weaned her, and then she died in the ICU there up at St. Vincent. So, yeah, anyway, so that was that. So pretty crazy in the moment, not knowing, I mean, just the drastic decline in her condition and allergic reaction, COPD, what the heck is it? And didn't see that coming, that's for sure.
Appreciate that.
Yep.
When we talked about that the first time, I was like, yeah, you got to, and he goes, I know. And that's something we had to tell everybody. It was interesting. It really is. Next up is Dr. Jackson is going to talk about EMS approach to stroke and stroke mimics. Thank you.
Exciting presentation. I don't think mine's been that good. Good work intubating that patient. That's like everybody's gonna make your sphincters flutter. So we're gonna talk about stroke and stroke mimics today. The goal is to hopefully get better at recognizing both so that we are better able to treat both. So quickly going through the definitions here, a stroke is obviously a disruption of the cerebral perfusion that eventually causes cell injury and then death. And then a stroke mimic is any disease process that's going to mimic that process. Some epidemiology here for you. Strokes are the fifth leading cause of death in the United States. One of the leading causes of morbidity and disability in the U.S. And there's a global lifetime risk of 25% if you make it to the age of 25. Some brief pathophysiology. I don't want to get too far into the weeds here because we want to focus more on the stroke and recognizing all those. But there's two types of strokes, hemorrhagic and ischemic. For the purpose of this discussion, we're going to be focusing on those ischemic strokes because those are the ones that mimics are mimicking. Hemorrhagic, the risk factors would be severe hypertension, coagulopathy, vascular malformation, amyloid angiopathy, vasculitis, other vascular malformations. For ischemic stroke, it's typically caused by an artery that's supplying blood to cerebral tissue. The cause is ultimately identified in only about 50 to 75% of all stroke cases. The majority of those would be cardioembolic, and then after that, it's more small vessel disease, and then you got your large vessel occlusions, and then under that would be your arterial dissection. For medium and large vessels, the pathophysiology is that acute plaque rupture and that plaque propagation that blocks out that vessel. Small vessel disease is a little bit different. It has to deal with the lipohydrosis of those elastic branching vessels because they're so small and they're in small spaces. They're more likely to occlude with that deposition. And those lead to your lacunar infarcts. They're also more likely to transform into hemorrhagic stroke. So treatment, you've all heard the term time is tissue, time is brain. This is why your role in this pathophysiology is so critical. Getting to those patients quickly transporting them, but early recognition and early identification of when that patient was last known well, because that's when these times are based off of. We can perform thrombolysis, so TPA or TNK, for within a 4.5 hour window of last known well, and then convectomy, or thrombolysis within 24 hours from last known well. And that's only for large vessel occlusions, which are the bigger vessels that we can actually access with those mechanical instruments. Otherwise, after that, it's focused on preventing further damage from the stroke and preventing further strokes. So again, just crucial that we recognize these things early so that we can treat them appropriately. This is probably too small for a lot of you to read, so I will limit this slide a little bit, but I just want to briefly go through the contraindications to thrombolytics because these are important for you to know so that you can identify these things in the field and bring that information to us. That's super helpful for us in the ER in making the decision on whether or not to involve thrombolytics. Because oftentimes these patients are aphasic, they can't necessarily speak. Information gathered from the field, from family, prior to family arriving in the ER is super helpful to give us in the emergency department. So obviously if someone's presenting with a subrectal hemorrhage, you don't want to give them something that's going to bleed more. But the specification here is also that if their clinical presentation is suggestive of subrectal hemorrhage, even if their CT is negative, you don't want to be giving those patients thrombolytics. If they have a known structural vascular malformation or neoplasm, obviously those are higher risk for bleeding. Suspected aortic dissection, don't want to be giving those thrombolytics. If they've had neurosurgery, significant head trauma, not just like a bump your head on the cabinet, but like talking about like a baseball bat or a significant MVC to the head within the past 3 months. And then any active bleeding diastasis, so thrombocytopenia, if you're on a direct oral anticoagulants or warfarin and your INR is 37, and any other risk factors that would promote bleeding. The other contraindications are focused on the mimics. You know, obviously you don't want to be giving a high-risk medication to someone that isn't actually having a stroke, right? Because those patients are still at risk for bleeding. I will say though, the thrombolytics, you know, it's a high-risk medication. It's dangerous because it can cause bleeding, and you know, the big complication is intracranial hemorrhage, which obviously has a significant amount of morbidity. But when we do mess up and we give thrombolytics to stroke mimics or patients that aren't having a stroke, the limited data out there, because it's a very small sample size, suggests that the actual risk of having intracranial hemorrhage following thrombolytics for those patients is quite low. Typically, those patients aren't the ones that have all the risk factors that lead to bleeding, so they're a little bit lower risk for bleeding result from thrombolytics. So up here on the contraindication list would be for the seizure at time of onset of symptoms, or if their blood sugar is less than 50. So we'll talk more about that in a second. So, focal stroke symptoms should correlate with the vascular territory. So, for patients complaining of numbness or weakness, it should be hemiparesis or hemi hypoanesthesia, rather than both sides in rare circumstances. And then a good way to differentiate between true stroke and stroke mimics is that stroke mimics often have positive symptoms or irritative symptoms, whereas strokes have ablative or negative symptoms. So a stroke causes complete loss of sensation, so numbness, rather than tingling. Oftentimes, mimics will cause positive symptoms or tingling in addition to the numbness. Similarly, they'll cause like pain, like migraine is headache in addition to neurotics. Keep that in mind as we go through this. So most common by far is hypoglycemia. This is why you guys need to be getting a finger stick in the field for any stroke patient. Typically, once your blood sugar falls below the level of 50, you can develop stroke-like symptoms, most commonly dysarthria. I think every hypoglycemic patient I've seen, sugar in the 20s or 30s, is heart in some capacity. It's some very similar pathophysiology as actually having a stroke, but it's essentially just starving your neurons of nutrients, right? The same sort of phenomenon. Treatment, obviously, you want to give IV dextrose, IM glucagon, and field if you don't have an IV. And then similar to hypoglycemia is the hypo everything else or hyper anything else. So mainly electrolytes, predominantly sodium is a big one. But really any of these can cause some neurologic symptoms. Most commonly numbness, tingling. It can also cause weakness. It can cause altered mental status and changes in speech as well. Another common cause of stroke mimic is partial seizures or focal seizures. These are seizures that originate in one area of the brain. They can still be complex, meaning the patient loses consciousness, or they can be simple and the patient throughout the day. And then following that seizure, they develop pause paralysis. So that's just a catch-all term for neurologic symptoms, focal neurologic symptoms in the post-ictal state. So this it can rarely be very similar to stroke. If you have a focal seizure and all you get from it is paresthesias and weakness of an extremity, without pain, without the automatisms or twitching or clonus, that can be very difficult to recognize. So this is very challenging, certainly. Obviously, treatment you want to treat with the underlying condition causing the seizures. Use anti-epileptics. Really, the diagnosis is key. The key here also is that this is going to be transient. Eventually, that post-ictal state will wear off, and the patient's neurologic function will come back. Unfortunately, it can still last for several hours at times. And so when you guys see them in the field, when they line up in the ER, they're still having those symptoms. It's going to be hard to not treat them as a stroke. And sometimes these patients get thrombolytics and then they get better and we're like, oh, it was a stroke. Truth is they just had a partial seizure. Migraines are extraordinarily poorly understood phenomenon and can be also very close mimics to strokes. The aura is a neurologic phenomenon that occurs both before, after, or during a headache. But the thing about these is that sometimes you can get an aura without the actual headache. So most ischemic strokes don't cause pain, right? Your neurologic tissue, your cerebral tissue doesn't have pain fibers. So headaches if you don't get a headache from a stroke. If you get a stroke and then you get cerebral edema that pushes on your meninges, then you would get a headache from it. So typically, like if someone's having a headache, you're not thinking about a stroke. But when a migraine has an aura without an actual headache, it can be very difficult to differentiate between these. There's a couple of genetic disorders, mainly channelopathies, that can cause increased predominance of this. And they can really mimic strokes pretty similarly. You can get true focal neurologic weakness or numbness. The last sometimes you can weeks, is reported in literature. Difficult to diagnose, certainly. Peripheral neuropathies. I think the big one, that you're going to see a lot of is Bell's palsy. It's difficult to discriminate this from a stroke. The main thing that you need to know is that the upper motor neurons that control your facial movement and your facial nerve cross when it comes to the forehead innervation. So with Bell's palsy, it knocks out the entire facial nerve peripherally. So you're going to get loss of function of your entire unilateral face. Whereas with a stroke, you're still going to be able to move your forehead. Having the patient raise their eyebrows or frown, you should still be seeing that eyebrow move or seeing those forehead muscles fire. Quick note on that is, with the increasing predominance of Botox out there, just be aware of that. That would obviously disrupt your exam here. But you don't want to be giving TPA to a Bell's palsy. And then there's, a whole host of other peripheral nerves that no one is getting to here, but, classic one would be Saturday night palsy. You had a little too much to drink, you fall asleep on a stool with your arm hanging off the side, you develop a radial nerve injury and wrist drop from it. But there's also, just plain old lumbar radiculopathies, cervical radiculopathies. Typically, all those will present with some sort of sensation other than just numbness. It's usually not just true numbness. That's where the positive or the irritative symptoms come in. So that's like tingling, pain with, it's pretty rare to have sciatica and just have numbness. You usually have pain with movement. They can complain of weakness, but they also have pain and tingling, those positive symptoms. Another big one, psychogenic phenomena, conversion disorder or functional neurologic disorders. These kind of fall into 4 categories. One big one being functional seizures, but there's a whole host of others. These can be quite challenging for us to deal with. I totally appreciate that it can be difficult to deal with these patients because to us they're like faking, right? That's the classic, like I mean, yeah, I've seen you move that arm before, like they're faking. But the truth is you want to build trust with these patients, because that's the ultimate treatment is addressing the underlying, psychogenic phenomena. Do this. Most of the time, they're not actually. Most of this isn't volitional. Oftentimes, it's something psychogenic that's truly doing it involuntarily. So just a plug out there to you're seeing that psychogenic seizure that's clearly psychogenic. Not to necessarily call it out. There's no supportive care to like. And these are very poorly understood. We don't know a whole lot about what they can look really like a true stroke at times. A big one to be aware of, and this is more so just to recognize that the dizziness can be caused by a stroke. So vertigo is often the isolated presenting symptom of a posterior circulation stroke. So something to be aware of in grandma that's suddenly dizzy, vomiting. It's not always the peripheral vertigo. In the ER, we would discriminate this with our HINTS exam. That's head impulse. I forgot what that means. Yes. But you're essentially looking for abnormal nystagmus and abnormal corrective saccades with head movement. Just important for you guys to recognize in the field, because you can, if you guys miss it, oftentimes we get into this anchoring bias where we miss it too. And that has a lot to do with this, which would be all intoxicants. I think every ER doctor out there, if you practice long enough, you've taken care of a patient that came in as a drunk, but ended up having a stroke or a brain. So we have to be very cautious and that's what I want to reiterate to you guys, that out there in the field, just because someone knows of alcohol or they were at a bar and symptoms started, doesn't necessarily mean that it's primarily alcohol induced. Yes, alcohol causes dysarthria. Yes, it can make you loopy and weak, and it can be difficult to get an exam on these patients. One of the worst strokes I took care of in residency, this poor young lady was 18 years old. She had a mechanical mitral valve from rheumatic heart disease that she had when she was a kid. So she was supposed to be on Coumadin for her life, and being a young lady, she was like, you just stop taking it. So she was actually on her way to downtown Chicago bars with her friends when she developed an acute left MCA stroke. Was dysarthriatic, was having trouble moving the right side of her body. And then, her friends recognized something was wrong, brought her to the ER. But it took us, a good 90 minutes into her ER stay to recognize that she was having a stroke, because she had just been drinking. She was taking shots. Her friend admitted that. And so she was put into this anchored diagnosis of being intoxicated. So just remember to have a high index of suspicion. On your drunks, make sure you're doing a good, the ones that are passed out, doing a good sternal rub, making sure you're getting withdrawing in all four extremities. There's equal facial movement there, speaking in their way. Another big one that's I think that's relevant right now, coming into the winter months with everyone turning on their generators, everyone, potentially, those people without a working HVAC might be burning some things they shouldn't be burning to heat their homes. Carbon monoxide poisoning is a direct neurotoxin, and it can present with photoneurologic symptoms. Typically, it has a whole host of other symptoms, which can be very difficult to recognize if you guys don't catch it in the field. Carbon monoxide is odorless, so it's not something you're going to necessarily recognize unless you have a high index of suspicion. But these patients will present with a flu-like syndrome, but really they can have just isolated neurologic symptoms without those other. So again, one of those things you can take account in the field for us. So to summarize, some good way to discriminate between all these is that the ischemic strokes don't typically cause So if patients start having pain plus symptoms, it typically it means something else is going on. You know, that's where that ablative versus irritative phenomenon is. Numbness is ablative, tingling is irritative. And then isolated dizziness definitely can be a stroke, so be aware of that. We need a high index of suspicion for all of our intoxicated patients. Just because they're intoxicated doesn't mean they're not having a stroke too. And then just avoid, you know, anchoring on those death numbers. And that's not all I had. I guess I went through all this. Your focused approach, and obviously you want to do ABCs first. For us, it's super helpful if you guys get a last known well in the field, and know if that last known well is when they went to sleep or not. You know, the wake up strokes can be difficult to determine because the patient's going to call you guys, like the patient, you know, in our the case woke up, went to the bathroom or tried to go to the bathroom and fell. They're going to say their symptoms started 30 minutes ago, but truly their last known well was before they went to sleep. Because we won't always have access to those family members that can find those things. So super helpful if you guys come in with this story. The finger stick glucose is the 6th vital sign. Make sure you're getting on those on all of your strokes and patients. Make sure you get a stroke scale in the field. Super helpful for us. And then be aware of the contraindications to thrombolytics and bring that information with you if possible. That's helps us out a lot on that. And then keep in mind the context of the presentation. Evaluate for other mimics. And that is all I got for you.
Could you touch on the mimics, stroke mimics with UTIs and how they present sometimes?
Yeah, so I mean, there's a whole host of infectious things that I kind of left out of here because they're, it depends on the infection, but elderly people that are have a lot of comorbidities are very prone to mental status changes when it comes to small infections like a UTI. It may not be septic, but it still might affect their mental status. Typically, that wouldn't cause necessarily focal neurologic symptoms. So they might be confused, but they shouldn't have dysarthria, weakness, hypoesthesia with the confusion. If one of those focal neurologic symptoms is present, then you should be thinking potentially something else. There's always mass lesions to brain tumor, an infectious process like an abscess pushing on the brain too that can cause meningitis as well can present with focal neurologic symptoms when it's advanced. Is that what you meant? Or
Yeah, just kind of. I see a lot of that. I mean, it seems like that happens not unright.
Oh yeah, that's a big complaint that we see. Any other questions? Appreciate it. Yeah. Thank you.
All right, guys, couple of housekeeping things, of course. So here's the QR code. Sign in, make sure that you, if you're here in this building, please sign in the sign-in sheet up here. Next audit review will be second Tuesday, January at regional. Normal times, advisory committee also at 8, and then we'll do the regular. I want to wish everybody happy holidays, Merry Christmas, Happy New Year coming up. Be safe. For those medic students, thanks for coming, and for you taking your test today, good luck. So that's it. Thanks, guys. I appreciate it.
Screw up.
Our entire future.
No, but it looks more.